Well, I shall take that hush as a cue. I am delighted to welcome you all here today. My name is Jenny Hyam. I'm the principal of St George's, and I have to say I love inaugurals. I think they are fantastic occasions, and this one, I can assure you, will not disappoint. There are many things I could say about Tess, and indeed Judith, who's going to give the vote of thanks at the end. Oh, shut up, Jenny, sit down. But one of the many things is Tess is a wonderful supporter of many of the events that we have, lectures, talks, and other people's inaugurals. And in fact, at the end of them, the last 2 or 3 times, she's been saying to me, I'm thinking about what I'm going to do for my own. And finally, the moment is here, it's your own. Just to say how proud we are of everything that you've achieved. You began at George's and you've flourished in terms of your career here at St George's, which is fabulous. You might have been called a poster girl, we can't say that anymore, but you're certainly one of our poster professors. And what a fabulous role model in all regards, at a time when we want to encourage more people into general practice, and as a specialty, academic general practice is withering on the vine. And what a better example than you to show how you can combine all those elements, but also, frankly, with such a wonderful personality. I arrived at St George's just over 2 years ago, and it's quite nerve-wracking, disconcerting, and always from the very beginning you were very warm and welcoming, and it wasn't a place that regularly had parties, and so I tried to throw a Christmas party, and there's that awful moment when the music strikes up and nobody's on the dance floor. Putting into action how activity prolongs health. So I've never forgotten that of you, so thank you very much. So we've got various constituents in the room, from obviously here at St George's and academic colleagues, fellow colleagues from general practice, friends and family. And that makes the occasion very special. It also means that many of you won't understand the questions that other people are going to ask. So if you have some difficult questions, we'll take them upstairs over a drink. We won't be taking them at the end of the lecture. And finally to say, we are going to put on a reception afterwards. Normally we provide the usual Van Medier wine, but knowing Tess's personality and possibly knowing the audience, I have it on good authority that she's ordered an extra 20 bottles of bubbles. So she is expecting a bit of a party to follow. So before then, we'd like to hear from you. So thank you very much.
So it's lovely to be here tonight talking to you about my inaugural lecture. So seeing the woods and the trees, and this is populations, patients and the promotion of health in primary care. And I know some of you have come a really long way, so far away as Aberdeen, Devon, Cornwall, Oxford, Kent, lots of you from Reading, Caversham. So thank you all for making the journey here tonight. And thanks to those who've come after a hard day at work at St George's as well. Great. And I've got all ages. I think my 4-month-old is just exiting out the door. And we got up to the age of 84, as far as I know. So big age range, and I hope to engage you all with some of this tonight. So what I'm going to do is first of all take you on a journey of how I got to become a Professor of Primary Care Research. And as part of that journey, I want to share with you what I think is a really important theme, this idea of being able to see both the woods, the population approach, and the trees, the individual patient or participant perspective. And I'm going to look at those in terms of research, teaching, and clinical general practice. And I hope to show that by kind of having both approaches, it enhances the performance in all of these areas. So this is where the journey starts. I was born in Chatham in Kent, the youngest of 3, 2 older brothers, Glenn and Stephen. Very happy and loving childhood. Also one where academia and education was seen as a very positive thing. My dad was a senior lecturer at what was then the South Bank Polytechnic. My mum was a primary school teacher. My dad had a favourite saying, which I think is probably still his favourite saying, which is cultivate your doubts, which comes from Goethe, I believe. And it's been a great motto for someone who's actually had a career in academia and general practice, both of which the ability to kind of tolerate and hold uncertainty is a big advantage. So thank you for that, Dad. So why medicine and why St George's? There wasn't anyone in our family who'd ever done medicine, but I remember really vividly at about the age of 7 going to see the GP with really bad tonsillitis, and he talked to me, he examined me, and I just felt better. And I thought, God, I remember thinking I really want a job like this, and I didn't really waver from that. And why St George's? Well, that's a bit of luck, really. My brother, Glenn, was at that time living in Tooting. He was studying at Imperial. And he promised me that if I got an interview at George's, he'd pick me up on his motorbike and show me a good time. So I thought, okay. So I wasn't actually going to apply. You weren't on my list, but I put them 5th and got an interview, came along, and I just absolutely fell in love with the place. I thought it was so friendly, so warm, and I thought this is going to be home. So I came. Yeah. And this is my class of 88. Now this is called Spot the St George's Professors, for those of you who kind of work here. I went down to the archives with Carly to dig some of these out. And there's also this guy in the front row here. You might not recognise him, had a lot more hair then. So he was 2 years ahead of me, and we got together in the medical school bar, very close to where we're going tonight for refreshments. So I've got a lot to thank St George's for. And here we all are today, actually. And what I find quite surprising is actually it's 30 years this summer, in fact, since I qualified. So we're not looking so bad, I don't think. Okay, so I had some amazing teachers at St George's, both in the individual clinical methods, the trees, listening to the patient perspective, and in the population approach. So in the clinical methods, I'd like to commend a couple of people, Professor Joe Collier, who's here tonight, who inspired generations of us medical students with an absolute love of clinical pharmacology, medicines management, and also of the NHS. So thank you, Joe, for that. Douglas Maxwell, who was a fabulous clinician. I was on his junior medicine firm, and I also did his house job. And when we were medical students, we were absolutely terrified when we got put onto Dougie's firm, as it was called, because we knew there was no hiding, and you would be found out. But we also secretly were really, really pleased, because we knew at the end of the 10-week attachment, we would have learned how to take a history, how to examine, and we'd have clinical skills that would last us a lifetime. So lots to thank him for too. And then it was also a great time to be learning about the population approach. Professor Ross Anderson, who I think is also here tonight, was developing the epidemiology and public health, the new curriculum in that. And Martin Bland was teaching medical statistics, both inspirational teachers and people who really wanted students to think and to learn and to question. So I really feel that that was the time when I had some seeds sown about an interest in population approach. On with a few years of hospital jobs and then general practice, and I'm very pleased that my GP trainer, Neil, is also here tonight. Had a very happy year in general practice training in Oxfordshire, Sturt Street Practice in Abingdon. And it's a great year as a trainee, because what you do really is you work as an apprentice. You learn the craft of general practice under a master, and you get to see a lot of patients. You really absolutely learn that general practice is kind of cradle to grave, that you'll see all sorts of conditions and you learn to kind of manage them. You also really learn about your population as well. And I'd like to take you back to 1992. This was pre-mobile phones, pre-sat-navs, pre-out-of-hours general practice as we know it. And when you were on call, and that's the practice area there in the big line on the outside that we covered, and we covered our practice and another practice. It was over 20,000 patients that you were on call for. You had your car, your doctor's bag, your bag of 10p coins, so that you could kind of go to all those phone boxes in between patient calls, answer your bleep and go on to the next one. And you absolutely, in the course of a weekend, got to know what your population, who they were and what would possibly go wrong with them. And all those little black dots, they're the pubs and the telephone boxes that Neil said to me, you absolutely need these as your markers because you mustn't believe anyone when they tell you and they're living in a house that's got no number, in a road with no name, in a village in the middle of nowhere, in the middle of the night, and they'll say, you can't miss it. And you absolutely will. So it was a great year, and at the end of the year I think Neil was quite surprised that I asked him for 2 references. One was to go and work in India, and the other one was to do an MSc at the London School, and I think he thought he'd lost me to general practice, but I did come back. So I went off to work in India for a year. So this was on a community development project called Samuha in Karnataka, southern India, covering 30 rural villages in a very deprived, poor part of India. And I worked on the health programme, so I was training traditional birth attendants or DIs who do deliveries, and also village health workers. And I learned a lot of individual clinical skills, because obviously it's a time when you're quite remote from any help and you really do hone your clinical practice. But above all, I learned about really what a population approach to health means and the importance of prevention, of immunisation, of antenatal care, of sanitation, hygiene, and all of those things that make such a huge difference to health. I also really learnt about the value of working with other sectors. I was on the health programme, but we worked really closely with community-based rehab, farming, fisheries, water, and particularly with education. And I learnt particularly the importance of educating girls, particularly not just for their own development and health of their families, but for the health and development of communities. So it was a very powerful time for me. Came back and did a master's in epidemiology at the London School, and I'd kind of been thinking about this when I did my trainee year, because I thought actually I was interested in a career in academic general practice and thought this would be a really good tool for that. Many of you may have had the chance to either study or work at the London School, and you'll know what a fantastic place it is. It feels sometimes like the whole world comes through and you get to be exposed to some amazing people and some amazing ideas. And that's my cohort there, and there's us at our 20-year reunion. I know some of them are here tonight, so that's great. Many of you might remember Tony Kendrick, who used to work here, who's now a professor at Southampton in primary care. And I remember him saying to me, you know, Tess, if you want to get on in general practice research, you need to get yourself an ology. So this was my ology. Okay, but what does it actually mean? What is epidemiology? It comes from the Greek, and it's the study of what befalls a population. It's that branch of medicine that deals with incidence, distribution, causes, and control of disease. And it's really the basic science underpinning public health. And I hope you all bear with me to do a little tiny sidestep while I'm talking about epidemiology and primary care epidemiology, to introduce you to this guy, Julian Tudor Hart, who was a previous St George's graduate, a bit before me, 1952. And he's one of those giants on whose shoulders we stand, really. He showed that it's possible to be, GPs can be natural epidemiologists working in their practices. He worked for over 40 years in his practice in Glamorgan in Wales, but also studying their populations. And this inverse care law that he published in 1971 is as true today as when he published it. Important for us to kind of remember. So he talked about the availability of good medical care tending to vary inversely with the need for it in the population, and that it operates most completely where medical care is exposed to market forces. I think that's something when we think about the NHS and the threats of privatisation that's important for us to remember. So I was at the London School doing my MSc, halfway through it, and I saw this advert for a lecturer in general practice post, and I thought, well, that would be the perfect job, but unfortunately I've still got 6 months of my MSc to do, not much point applying. So I rang the number on the advert, and Sean Hilton picked up the phone and persuaded me to apply for it, and I got the job, and actually I've been here ever since, so that was a great phone call, Sean. Sean's been a fabulous mentor in general practice for me. Many of you will know that he developed the undergraduate curriculum and also academic general practice as a discipline here at St George's, and I've been very lucky to have him as a friend and guide over the time of my career. So thank you, Sean. So at that time I then really have been working in the same way really since '94, in a triple kind of way of working, doing research, teaching and clinical general practice. And the first general practice that I went to work in from here was Bridge Lane. I've got a few from over here. And the previous, I'd like to note the previous senior partner and the current senior partner, Liz and Sheila, who are fabulous female mentors to me, and I learned a huge amount of general practice from there. I loved working in inner city general practice. It's very exciting, very varied, huge variety in our population, from some really rough council housing estates with lots of problems, and also lots of very affluent areas and gated palatial bits by the river as well. So a real variety of general practice. I learned a lot, but two particular things I think that I carried with me and that have been very important in the practice I work in today. One is the value of a coffee break, the importance of actually meeting with your colleagues at the end of morning surgery and kind of having a chance to debrief and chat about what's happened. And secondly, the idea of having an open door policy. So when you don't have a patient with you in practice, your door is open. People come in and talk to you and ask you things, and you go into their rooms and ask them things. And I think both of those things improve hugely the quality of your general practice, but also the enjoyment and fun of general practice, and actually making sure that you still you don't get burnt out and you still love the job. So. Okay, on to him. Many of you will know Derek. Now, I think probably the most important thing that Sean actually did for me in my career was to introduce me to this guy, to Derek Cook, who's one of the epidemiologists, particular interest in primary care epidemiology. And I think what Sean recognised was that if I was going to grow and develop as in my career, I really needed to work closely with some epidemiologists. And in fact, Derek and I have been working together, I think, for nearly 20 years, so very productive and happy collaboration. So this was the first tranche of work we did was what led to my MD, which Derek supervised. So this was about developing a methodology for predicting primary care use in older people, and focusing in particular on depressive symptoms. And what we were trying to do, which was quite novel then, was the idea of doing a big survey of older people, asking them lots of questions about their health, their social circumstances, their psychological factors, and then also asking them if we could link that data to their primary care records, which have rich data on their consultations, their prescribing, etc. And it hadn't really been done. And as I kind of came back and looked at this and thought about it, I thought actually this typifies why it's so good to work with Derek, because what he has is this appreciation of what are the important big questions, and in this case it was about linkage of a database with a survey, and then the kind of minutiae and the detail about how you actually go about answering those. And that kind of combination of the big picture and the detail, I guess more of the woods and the trees, has been why it's been so good to work with him, and why I've learned so much from that. So thank you, Derek. Sorry to embarrass you. So South London self-study. So it was actually successful, and people did answer the survey, and they did give us consent to link to their records. So we managed to produce a lot of interesting papers out of it, and we were actually amazed that over 75% answered the survey, and over 92%, so 92% of those who answered gave us consent to link to their records, which was great, and we were able to actually download those and link the two. And we looked at the predictors of depression, and we found the strongest predictors were loneliness, disability, and poor health. We found that depression did predict consulting, but actually most of the older people with depression had very poor physical health, and once you'd controlled for that, the depression itself wasn't an independent predictor. And the strongest independent predictors were actually chronic disease, poor health, anxiety, and isolation. So it was kind of very interesting work, and it also really got me into the area of looking at older people's health, and interest in kind of what we call multiple morbidity, when people have many different conditions, and particularly when there's that combination of physical and mental ill health. So it was a very productive time for me as professionally. I got my MD, I got established as a principal investigator, but it was also a very productive family time. This is where I embarrassed my family. So it was a time when Nikos and I had our children, Alexis and Katya. We moved to Reading. Very proud to have Alexis here tonight. Katya's now big enough to be on her gap year. She's somewhere in Indonesia, so we're recording it on Panopto, and she'll get it when she next has Wi-Fi, I think. And they've all been incredibly supportive of me. Many of you will know that academia and also general practice are really hard for family time. They cut into evenings, weekends, etc., and they've been nothing but supportive. And I think there was a point when I was trying to complete my MD where I was kind of feeling it was never going to happen. And Nikos just swept them both up, took them to Cyprus for a week, and I think I wrote 4 chapters in 7 days, and it was really good. But despite being very supportive, I have to say that when they were both little, whenever they were actually ill, they would always ask to see a proper doctor, a proper GP. Okay. So just for a moment, just going to pause for a moment before I take you on to kind of the science of my recent and current research. I just want to say some other really important thank yous to people who've been enormously supportive along the way. So I'm going to embarrass some other guys now. So this is Professor David Strachan and Peter Wincott. Many of you will know the previous and the current head of the Population Health Research Institute. Both clinical epidemiologists, incredibly wise, fabulous leaders, really, really supportive. And also both with wicked senses of humour, actually. So I've been very lucky to be in their institute. Both of them absolutely got the Athena Swan agenda before it was ever raised as an issue. They have always supported women in research, people who work less than full-time in research, and they've also absolutely seen the importance of primary care to a population health department. And when I look at colleagues of mine who are elsewhere, not at St George's, and the struggles that they have with their kind of heads of department and institute, I feel so very lucky to be where I've been. So thank you. And more embarrassment. So there's 2 fabulous female mentors. So Sally Carey and Christina Victor, both initially from St George's. Sally now at QMUL, Christina at Brunel. Sally's been enormously helpful in kind of the big picture, the population type of research. She's a trialist and she's held my hand through 2 clinical trials and shown me how to run an effective and successful trial. So thank you, Sally. Christina's been all about the participant and the patient voice, and she's taught me to listen to those trees and to kind of realise the added value that qualitative research can bring to quantitative methods and quantitative research. So thanks, Christina. And then finally, roomies. It's really important in research who you share your office with, and for many years, Chris, Judith and I shared an office together. And before, very happily, until Judith was torn off to IMBY, and I miss her daily wisdom and kindness. But luckily, she's head of general practice here at St George's, so I still get to work with her very closely. Chris has amazing big ideas, enthusiasm for research, and I'm very lucky still to be working with him because we're now both deputy institute directors, so we still get to work together. Now share an office with Alicia, very lucky to do that. She's a fabulous statistician who's as good with words as she is with numbers. And it's great when your research colleagues can also be your friends, which I've been very lucky with. So, on to some research. So, 2 particular different directions of research, one around physical activity and one around primary care database research. And I suppose just a moment about why an interest in those. The physical activity, I think this does really come from the interest in older people's health, and then a thought that really wanting to do an intervention that could be beneficial and that could help. Particularly something that could help with physical health problems and mental health problems. So physical activity seemed a natural choice, and also it was at a time in the institute when we were developing expertise in objective measurement of physical activity, so it fitted with that as well. Primary care database research, again, that also kind of stems from the stuff we did in the South London Health Study. There we were just looking at one primary care database for 2 different practices. The work we've been doing is much broader than that, so it's looking at kind of national data sets where you've got lots of GP data to answer important questions. So although they're both quite different, I hope to show by telling you a little bit about them how an individual and a population approach to both of these areas of research adds value. So physical activity. I know I'm probably talking to the converted here about the health benefits of physical activity. I'm sure you're all aware. But still, when you see something like this infographic from Public Health England, it's amazing. The whole range of different conditions that physical activity both protects against, or if you have the condition, it will reduce your complications from it. And we can see that if we could just get about a 10% increase in physical activity in the UK, we'd be able to prevent about 6,000 premature deaths a year. So really, really important. My trials have been with adults and older adults, and I think when you look at why physical activity is important for older people, yes, preventing disease is really important, but there's a number of other factors that are also really important too. And there's this great guru of physical activity called Nanette Muttrey, who works in Edinburgh, and she's got this really lovely saying, which is, everything that gets worse as you get older gets better with physical activity. And I think there's definitely some truth in that. So this is to make you all feel bad about what you have or haven't done this week. These are the guidelines, and we know we should all be doing about 150 minutes a week of moderate intensity activity, ideally in bouts of 10 minutes or more. We should be doing some strengthening activity, and we should be trying to minimize our sedentary time. So these are the guidelines for adults. Older adults, very similar, but with a particular focus on daily activity, on building up gradually, and for those at risk of falling, also adding in some balance activities. We know walking's really good for you, and maybe even better than going to the gym. I don't know if you want to clock that one, Alexi. That's really but why is it such a good exercise, walking? Well, it's really easy to integrate into your everyday life, and it's got a low risk of harm. So that means if you take people who are very sedentary, who have got a lot of chronic health conditions, they can gradually increase both the frequency and the intensity of their walking in a safe way. And yet, if you're walking at around 3 miles an hour, for most people that counts as moderate activity. So it's enough, so that's getting you warm, getting your heart rate up, getting you breathing a bit faster. And if you're not sure if you're going fast enough, you try singing, because if you can sing, you're not going fast enough and you need to speed up a bit. You should be able to talk but not sing. And we can measure it objectively, so that's really important, because questionnaires are pretty bad with physical activity generally, but for walking they're really quite hopeless. It's very difficult to remember accurately how much you walk. So we can measure the steps with pedometers, and we can also measure the time that you spend in light, moderate, vigorous activity with these accelerometers. And there's a really nice relationship between the steps and the intensity, so that for most people, if you're walking at a moderate intensity, that's about 100 steps a minute. You multiply that up, that's about 3,000 steps in 30 minutes. So if you can get people to add that on to what they're doing in their daily lives, for most of them they'll be hitting the guidelines with that. And that was one of the messages we had in one of our trials. So I'm going to just take you briefly, just give you a snapshot of 2 trials that we've done in primary care, both walking interventions, pace lift and pace up. And you'll see there's a lot of people named on there who've been really important in both of the trials in terms of the collaborators and investigators on those, and a range of different institutions who've been involved. And I'd like to say a huge thank you and acknowledge all of the people who've had input and made them successful, both funded by the National Institute for Health Research. So pace lift, this was the first one we did, and this was aimed at 60 to 75-year-olds, and the aim was to increase physical activity, particularly walking, using a 12-week pedometer intervention. We had recruited 300 participants from 3 practices in Oxfordshire, Berkshire, so near where I work as a GP, and they were randomly allocated into either a control or an intervention group, and we followed them up at 3 months, 12 months and 4 years. Pace up, this was a broader age range, so this was 45 to 75-year-olds, also a 12-week pedometer intervention, and this time this was done in southwest London. We recruited just over 1,000 participants, and we allocated those into 3 groups. This time we had a control group and 2 intervention groups, so they either got the intervention by post, or they had some additional nurse consultations as well. And the follow-up here was 3 months, 12 months, and then long-term follow-up at 3 years. And this is just to tell you a little bit about the pace lift intervention, and I'm really lucky that I've got 2 of the nurses here tonight, Pam and Rika, so thank you for coming and thank you for all your input into the intervention. So what we did in this was practice nurses saw the patients and they discussed health issues with them, found out what their baseline daily steps and the time they were doing at baseline in different intensities of activity, and then got them to set some individual achievable goals and use behaviour change techniques to help them to build lasting habits for changing and increasing their physical activity. Pace up, the intervention there was again a pedometer, a handbook and a diary, but this time we were a little bit more didactic about the walking programme, because one of the groups, the intervention groups, was a postal one, and we had to kind of provide something that was kind of easy to follow. So we advised people to start from their baseline and to gradually add in an increasing number of steps over the 12-week programme. And so that was the postal and nurse group got all of those, but the nurse group additionally saw patients 3 times, either on their own or as part of a couple if they preferred. So we had really good follow-up rates. You can see over 90% at 12 months in both of the trials. And in PACE-Lift, we managed to get 3/4 of them at 4 years, and in PACE-Up, 2/3 of them at 3 years. So yeah, very happy with the follow-up figures. And then just to take you through this, which looks a bit complicated, but actually it's not really. So this is the main results from both of the trials at the 12-month period and also the follow-up. And I've put both of the trials on there because actually there's great consistency in the results, which means it makes sense to kind of show you them together. So here we're looking at the change in the total weekly moderate to vigorous physical activity. Remember, that's what's in the guidelines, that's what we know kind of it makes us have really good health benefits. And we're looking at time since baseline along here. And green is PACE-Lift, and then these are the 2 intervention groups, postal and nurse for PACE-Up. And if you treat this as the control group, this is showing you for each of the interventions how much additional moderate to vigorous physical activity they were doing at the different time periods compared to the control group. And what you see for PACE-Lift is at the end of the 3-month intervention, those in the nurse group were doing over an extra hour a week compared to their own baseline in moderate to vigorous physical activity, so way above what the control group were doing. In PACE-Up, there was actually a difference at the end of the intervention, and the nurse group were outperforming the postal group, but both of them doing more than the control group. By 12 months, what's amazing is actually how uncannily similar all of these intervention groups are across both trials and the 2 different groups in PACE-Up. So they're all doing about an extra half an hour a week compared to what they were doing at baseline at a year. And then we do the long-term follow-up. And actually, this is really what's quite novel about the trial, because before our work, nobody had actually followed people up beyond a year with any objective data. So this is the first kind of findings to show that sort of a short, simple intervention that's only a 12-week intervention can actually have lasting effects on people's activity. And what you see for the PACE-Up is that at the 3 years, postal and nurse group, again, performing very similarly, an extra half an hour a week and more significantly more than controls, and similarly slightly more, but again around half an hour a week at 4 years with PACE-Lift. So a really persistent effect of a very short-term intervention. And if I tell you that at the beginning of the trial, on average, all of these groups were doing about 90 minutes a week of moderate activity, an increase of 30 minutes that's persistent 3 or 4 years later. That's up a third on what they were doing at the baseline. And remember that that 10% increase would be something that would produce save around 6,000 UK premature deaths. So this is a kind of, a significant and important effect. So our challenge now is how do we kind of translate that into something for the NHS, and that's what we're kind of struggling to do at the moment, but we're very pleased with the findings. So that's the kind of the woods, that's the big picture, that's what on average happened for those groups in the trial. But actually what we're interested in is kind of the trees and the individual responses to that. So what did the participants and the nurses feel about the intervention, and what did it kind of mean for them? And I think when you do any kind of complex intervention and you get a result, that's great, but you've then got to unpick what was it about that intervention that worked. There were lots of components in it, what are the bits that make a difference? And that's where the qualitative evaluations have been really helpful. So we had a number of evaluations that went alongside the trials, talking to the participants, talking to the nurses and finding their views, and they really added a lot of depth to our understanding of the research. What I'm going to do is just share with you a few of the quotations from the long-term follow-up of PACE-Up. So people talked about increased awareness. I started thinking how much exercise I was doing, and I didn't realise you were supposed to get out of breath once a day. PACE-Up reinforced the importance of keeping up the exercise. It's a lifelong thing now. About lifestyle changes. I walk to places I would have driven, and how much I now enjoy walking, which I wouldn't have said a year ago. Before the PACE-Up trial, I had no incentive. It got me on the right track. And you started something, and I continued by myself. And then also about the health effects, and I think these are very interesting to look at. There were a lot of people who were like this lady in the first one, who saw their poor health as a reason to try and be physically active, as some kind of facilitator. So here she talks about, the more active I am, the better my arthritis is, and I need to be walking as much as possible to keep the joints lubricated. But for other people, definitely poor health was a barrier. I get pain, I'm not going out walking if I don't have to. What's the point of risking a heart attack or something? And then people talking about healthy aging. I feel happier after doing some walking, and if you don't use it, you lose it. So I think for me as a GP, I found all these quotes really interesting, and the idea that perhaps as healthcare professionals, what we really need to be thinking about is how we can help people who've got chronic health problems to kind of change those barriers into facilitators, and to try and see their kind of physical conditions as a reason to try and be active, and how we can help support them with that. Some more lovely faces here. So I've already said some thank yous to people who've been involved in the trials along the way. So Derek, Peter, Sally, Christina, Judith, all been involved in the trials. And here are some other really important people in the trials and making them successful, and their roles in those. And I think one of the lovely things about being in such a group when you're doing the trials is that, you know, there are moments when it's not working, it's all going wrong, and actually what's so lovely when you've got a group like this is that there's always someone who's either done it before, seen it before, and knows what you should be doing, or just has some really good idea about how you can kind of overcome that problem. So that's why it's been so good working with these people, and also just making it much more fun, having a great team to work with. So, primary care database research, a little bit about that. So this is when we use routine, general practice, computerized databases. We use anonymous data that's collected in general practice to answer questions about health service use, and health outcomes. And this work is all done, I've done all this work as part of a group that I'm in, the primary care epidemiology group, so that's led by Derek Cook, two fabulous statisticians, Ian Carey and Faye Hosking, and myself and Steve DeWild as the GPs in the group. And you can see a range of the different types of work and publications that we've had recently using that work. So looking at kind of bereavement and its effects on mortality, on its effects on the quality of cardiovascular disease management. Looked at care home residents, their prescribing, their mortality. Looked at infection in type 1 and type 2 diabetes. And we've answered questions like, do beta blockers improve cancer survival? So a kind of a whole range of eclectic questions, and we work with other investigators, you know, as and when. One person who's missing from that picture, many of you will remember, is Dr. Sunil Shah, who was a fabulous public health doctor who was very much part of our group, and we all miss him terribly since his death in 2015. So what I want to talk to you about briefly from this, as an example of this, is which I think another example of kind of where the population and individual approach works really well, is some work that actually was led initially by Sunil and then taken forward by Ian as part of our group, that looked at evaluating the effectiveness of health checks and quality of healthcare for adults with intellectual disability. So this is adults with learning disability, and this is using the primary care database to answer that. So it was funded by NIHR, and we worked with two really important patient groups here. So learning disability service users as part of ResearchNet, and then a group of carers, the Merton Carers Partnership, which is a local group of family carers of adults with learning disability. And working with these groups, which we did all the way through the project, really enriched the work by helping us to kind of think about some of what the important questions were to answer, and also in terms of understanding the data and interpreting it. So why research learning disabilities in primary care? Well, they're a group that has very high levels of health needs, and also actually evidence that they receive quite poor care. It was an opportunity for a natural experiment because the primary care learning disability health checks had been introduced into general practice. They were being carried out in about 50% of practices. About half of patients with learning disabilities were having them. But actually, they weren't being evaluated. Like many things that get introduced into the health service, it's a great idea, let's do it, but nobody was actually evaluating it. So it was an opportunity for us to do a natural experiment and compare people who were having the health checks with those who weren't, and actually evaluate their effectiveness. So this shows you the kind of data that we had. So we had anonymized data from the computer records from the GPs about learning disability, health problems, consultations, medications. We had data on deaths, deprivation, and we had data on hospital admissions. So really rich data set to answer some important questions. And this was the first tranche of work we did, which was around their kind of health and consulting. And what we showed was that compared with the general population, actually adults with learning disabilities had much higher levels of many chronic diseases and were more likely to consult. So if you kind of imagine that's the comparison with the control group, anything above 1, they have higher levels. So for all of these conditions, they had significantly higher levels than controls of the same age. But actually for some, they had really, really high levels: dementia, severe mental illness and epilepsy. So a group with a lot of problems. However, they were less likely to have long or double doctor consultations, shockingly. And they had lower continuity of care with the same GP. So, a group with high needs. We looked at their death rates, and they were much higher in adults with learning disability compared with the general population, and that's even after you controlled for the fact that they had a lot more illnesses and a lot more deprivation. And worryingly, more than a third of deaths in this group were judged to be preventable with better health care, compared to only a fifth in the general population. And then we looked at emergency hospital admissions, and we saw, probably not surprisingly, they were more likely to have emergency hospital admissions, again, even after you controlled for other illnesses and deprivation. And over a third of their hospital admissions were deemed potentially preventable, compared to only just under a fifth in the general population. So the last, this is where I knew it was going. Oh, that's good, that's worked. Phew, I knew there was going to be some hitch. Well, if it's just that, I'm quite happy. Okay, so this is the last bit of work we did was looking at whether the health checks actually made a difference in terms of emergency admissions. So here you can see in red those who are having no health checks, and in green those who are having the health checks. And you see at the beginning they're pretty similar, but over time they're kind of diverging, and there's a significant difference here in that those having health checks were having less of these preventable emergency admissions. So preventable emergency admissions, or what we call ambulatory care sensitive admissions, they're the type of emergency admissions that perhaps if you'd presented earlier in general practice, you might have avoided the admissions. So it's things like respiratory tract infections, urine infections, skin infections, those type of things. And what we saw was that there was just over a quarter, so 27% reduction in these preventable emergency admissions, which equates to about 12 to 16 per thousand fewer per year if you have health checks. So they are making a difference in some way. So again, that's the woods, that's the big picture, that's what the kind of on average the GP database shows us, those powerful findings. But we're also interested in kind of getting inside those and what they mean, and that's kind of looking at the trees. And I'd like to say thank you to Carol Bayton, who led on this work. So this was work actually published with the two groups that we worked with. I'm sure we made it a better study, and they absolutely did. The experiences of adults with intellectual disabilities and parent carers. And there were many ways in which they helped, but the two I'm going to pick out one was around helping us to generate new outcome measures. So those two things we told you about, the continuity of care and the longer appointments, they came out of the discussions with these groups about how important these things were. So some of the comments about continuity of care: I don't have the same doctor, it's not good. I want routine, I want the same doctor. And they know who you are, but it's jump around, jump around. And about longer appointments. You can get everything in on a double appointment, and you just can't get everything in on one. So in telling us kind of that these were really important outcomes for us to look at. And then also around dissemination. So we worked very closely with these groups in terms of disseminating findings. And actually, this is involved. This is part of NIHR that is particularly to do with patient and public involvement. And they picked up on this work that Carol published, and they thought it was really important. And they came and wanted to interview us, and they did a bulletin about the work and how important it was. Okay, so that was a gallop through research. I'm just going to say one very quick thing about teaching, because teaching is also a very important part of my work here and something that I really love. And as a generalist and someone who's got expertise in both sort of primary care and population health, I'm very pleased that I actually either teach or examine on all 5 years of the undergraduate curriculum here. But one thing I want to just share with you is work we do in the third year, the T year, of the 5-year curriculum, which is when students have just started to go out and spend a lot more time in clinical placements. And we try and teach them clinical epidemiology through the case analysis project. And this is trying to get them to apply the principles of epidemiology and public health to different cases. This was actually, again, Derek Cook's brainchild. He thought of this great idea. I just kind of lead the module now. But I think it's a really good example of how you can get students to think about the individual and the population and how that kind of really enhances their learning. So we get them to find a patient that's got a common chronic condition that they've seen either in hospital or general practice. We get them to tell us about the case and the investigations that they had done. And then we get them to think kind of much more broadly about it. We get them to think about the population approach. What's the burden of this condition? How common is it? How many people die from it? How many people present in general practice? So go and look at some routine statistics and apply it to this condition. We get them to think about the evidence base for treatment. Are there nice guidelines out there? What should the appropriate treatment be? And we get them to think about prevention and what the opportunities are for prevention. So it's a really nice example of getting the students to be able to kind of think both about the minutiae and also about the big picture and putting them together. And I would really like to thank all of the team of tutors that we have, which is a huge undertaking, this case analysis project, and the admin staff that we have who support this, because it's quite a complicated thing to teach and to administer, because all the students throughout the year all produce a project. It has to be marked and turned around in a very short time. So I particularly like to thank the administrators, which are Catherine Pigott and Sharon Clark, who do a fabulous job on that, and also Hugh, who I took over from, Hugh Thomas, who led this for many years before I've just taken it over and carried it on. But I think it's a really good example of where we're trying to say to the students, to get them to think about this kind of upstream, downstream picture in health, which I think they really need to kind of have lots of chances to be exposed to really get. Because yes, it is really important to fish people out the river and resuscitate them, and that's really important, but you also need them to start thinking upstream about why the people are falling in the river in the first place. And if you don't, we need them to start thinking about causes of diseases and not just consequences. Otherwise it's a bit like picking out the weeds without taking the roots out. So that's important. And then I'm coming on to the last bit of my 3 jobs. So last but not least is my time in clinical practice as a GP. So I've always worked in general practice alongside the academic role, and this is my current lovely practice in Sonning Common Health Centre in Oxfordshire, where I've worked for 17 years now, part-time as a GP, and a fabulous clinical team, many of whom are here tonight in that little row there. So thank you very much for coming. When I remember going for an interview at Oxford University for a job that I got offered and turned down, to say at St George's, and one of the questions that they asked me there was, do you think being an academic makes you a better GP? And I thought about it and I said, actually, I don't really know the answer to that, but I do know that being a GP makes me a better primary care academic, and I absolutely think that's true. I think what we do in clinical practice hugely informs our teaching and research. And what we do, we are the masters, I think, in general practice of the woods and the trees. We strive to provide excellent population-based, person-centred care. This is some of the stuff we do for our population. We immunise all our children, our at-risk adults. We offer health checks to try and detect early cardiovascular disease. We do cervical screening to prevent cervical cancer. And we take part in the quality and outcomes framework. And we might moan about that, and we might say, well, it's a lot of tick box, but actually it does some very important things. It forces us to really think about the populations of patients that we care for, all the patients with diabetes, with heart disease, with lung disease, so that we actually try and provide excellent care for all of them, not just the people who turn up to see us. So it's addressing that inverse care law that we heard about from Julian Tudor Hart, to make sure that we're actually trying to help everybody. We also do a lot of health promotion, particularly physical activity. You won't be surprised at Sonning Common. Very proud to say that Sonning Common was where the health walks started. A previous GP there, William Bird, who started those up. They're now a national and international phenomenon. We have a green gym. So these are all ways to try and get everybody active every day, whatever their health conditions. But the heart of what we do is that individual, one-to-one, person-centred care, the consultation, taking histories, examining, diagnosing, managing, curing when we can, caring and comforting always. And I think one of the amazing things about general practice is that, the next person through the door could be 1 day old, they could be 100 years old. They could have self-limiting illness, they could have life-threatening illness. It makes it very exciting and diverse, but it also makes it very complicated and hard. We follow up our patients really well as well. We see them many times. We see them over long periods of time. So we try and offer that continuity of care that the patients with the learning disability and their carers so value. And I think, when we're thinking about general practice, and today, there's a lot of stress on providing excellent access, and that is important, but we mustn't lose sight of, we mustn't kind of only do that and lose sight of the fact that we must also try and provide great continuity of care, particularly for those patients with chronic diseases who absolutely need it. And I thought it wouldn't be a proper inaugural without a little bit of Latin. So here's my Latin. So cum sienta caritas, which is from the Royal College of GPs motto, which is science with compassion, what my lovely GP colleagues are providing every day in general practice. And I think the magic of general practice is that real ability to put that woods and trees together, to be able to see for that individual person, that individual patient in front of you, to kind of know the evidence base, to know the population-based evidence that's out there, but to know whether it's actually appropriate for that 86-year-old lady who has 6 health problems, is on 15 medications. Is it actually appropriate to apply the nice guidance for depression, for heart disease, for whatever? And it's what Aristotle talked about as phronesis, or practical wisdom, which is, to be providing the best care for this patient right now. So I think, that's the end, and I hope that you feel like you've made it together with me and you're not lost in the trees like this guy, and that I've brought you along, and that you've kind of seen the value of the individual and the population approach for both kind of research, teaching and clinical practice. And I'd like to thank my home team, so this is my lovely family and friends, for all their support, for being there along the journey, for helping me not to take myself too seriously. And that's it, really. Thank you.
Well, that was just a fabulous talk, really, and just typical of our experience of you, Tess. Absolute clarity, focus, delivery. That's what we've come to expect of you. And I could just say thanks for being you, but I'm afraid I'm going to take a few more minutes from that and unpick what is the special essence of you, but hopefully not take too much time. So I'm a long-standing colleague of Tess. In fact, she interviewed me, and she's the reason I'm at George's. So I'm very grateful, first of all, for that to her. And I just want to really propose a vote of thanks for you tonight, and for not just the talk, but for being such a valued and inspirational colleague. So I'm going to hang my words around 3 aspects of Tess, which I think we have seen demonstrated tonight. First of all, her intellect and academic abilities, and her values, which infuse her work. And then, most importantly and evident to us all, are her people skills as well. So firstly, her academic prowess. And just to give you an image of Tess, which you'll all be familiar with, she'll be buzzing around with notes, pre-prepared notes for all the meetings that she's had all day, a cup of coffee in hand, shooting around very efficiently during the day. What she hasn't talked about tonight, because of her modesty, is her academic distinctiveness through her career. So she didn't tell us that her MSc dissertation gained a distinction at the School of Hygiene, and Derek told me today that when she did her MD, it was not only passed, but it was passed without any corrections at all. And that's very unusual, but entirely typical of you. Everybody who's worked with Tess at close quarters knows her to be someone with a deep understanding of the scientific epidemiological inquiry, and a passion for it, and focus, and an ability to deliver and also to work to deadlines as well. So she delivers, and she delivers on time. And we've all, the research community, the students and your patients have all really benefited from that, both in your clinical practice but also your research outputs as well. I mentioned your modesty earlier, and I just also at this point want to mention something Derek also mentioned today when we were talking about it, is one of the very special things about your academic abilities is your modesty, but also your ability to listen to other people and to learn. So just not to accept and think that you know everything, but actually be prepared to debate and listen and learn and improve. So just to give you an image of this, if you think about a pace-up steering group, very diverse group of people around the table, all bringing absolutely brilliant skills towards a project. But like any research project, there can be practical, intellectual, political, and sometimes emotional problems that come to the agenda. And Tess would successfully chair the group, pre-prepared, highlight all of the problems, do her options appraisal of what the solutions could be, listen, get people to collaborate, agree on a solution, and would finish the meeting on time as well. So really, really fantastic example of what she's like to work with. Just also briefly want to highlight something she hasn't said about the breadth of her work and the breadth of her teaching. So you've seen quite a lot of her work in terms of the database work, but she's also done work on HRT as well in her earlier work. And her teaching ranges from immunisations for the undergraduates to other topics as well. So things that she's not focusing on, but she will teach to a very high standard. And our Vice President for Educational Welfare has got a place to do medicine, and she happened to see Tess do a practice presentation a few weeks ago, and she said, I want to be her, and I want to do her job. So she's very inspiring for our students. Finally, in terms of academic contribution, I just want to say thank you on behalf of us all for your contribution to our work, because you bring all of your talents to other people's work as well. You're very generous in terms of your time, and you'll come and give us comments to the same kind of degree and quality that you use with your own for other people. And there are many people whose careers you've enhanced, so from students to junior researchers to colleagues and other collaborators as well. So thank you for that. So on to a bit about values as well, and we've seen a bit about that in your talk already. We saw your rather dodgy homemade placenta in India that you were using to train healthcare workers, and your choice of promoting health in an older population is very clear as well. But there are other aspects of your sense of fairness and social justice which infuse your work. And I think that's been really important in your very successful collaboration with the PHRI collaborators, so with Derek, Peter and David, and past mentors such as Sean and Joe, who's here tonight. And Joe particularly thinking about the influence of the NHS and the place of medicine in society and the potential conflicts of interest that can be around that. And our image here would be of you sitting hungrily outside a drug company lunch somewhere, refusing to go in and have the lunch, but be prepared to engage in the discussion afterwards. And finally, when we talk about values, I want to thank you for your loyalty to us at St George's. As you've said, you've been a student here and an SGUL lifer. But I really want to thank you for not accepting the job at Oxford. There are a few of us who had some very sleepless nights for a few weeks because we were saying, yes, it'll be great, yes, you should go for it, yes, it's good for you, yes, it's good for your family. But you decided not to in the end, and we all slept better and have had some very happy few years since then. But at this point, I also wanted to say thank you to Nikos and Alexi and Katia for that, because I do feel a bit guilty that our gain has been slightly your loss and slightly the railway's gain in terms of the cost of Tess's commute. But we really appreciate you sharing her with us when she could have had a bit more time at home. So finally, the bit we're all very familiar with, Tess the person. The size and diversity of the audience tonight is a testament towards the goodwill to which people feel towards you. And we all know that Tess is an exceptional leader and a connector of people. She's a product of her own confidence, I think, to show her great warmth and interest in and love of people that are around her, be they patients, students, colleagues, friends, whoever. You're very inclusive, you listen to people, you respect people, care for people, you get them to laugh, you get them to feel better. And so everyone just enjoys working with you, and people feel respected and valued. And we've already heard tonight that she's very generous with praise in terms of people that she has worked with. But she doesn't just tell people that they've done very well, she tells other people about how well this person's done as well. So she creates a very, very important social glue around the work that you've done. So it's not artifice or guile, it's just direct and authentic and new. But she's also not a pushover, and she's also, because of that ability to make connections, also fair and good at giving us robust feedback as well if she disagrees with us, or of telling us difficult things if things aren't going well. She'll tease and nudge us and try and get us to change, but also respect us if we don't as well. So that's fantastic, and thank you for that, Tess. And then finally, the thing that we all really enjoy about Tess is your, I'm going to really say this badly because Leander told me how to pronounce it earlier, but hopefully joie de vivre. That I'm getting a thumbs up. It's your immense lust for life that is really fantastic. And I remember you saying that what you'd really enjoyed about your Cypriot family, bringing that to you as a Cypriot equivalent that you really enjoyed, but I think actually you had that within you all the time as well, and it just matched it. And that is again a really good social glue for all of us in the community of St George's and outside. So I think we'll finish there, but I just wanted to say a huge heartfelt thank you from your friends, patients, collaborators, colleagues from the last 20 or so years at St George's and beyond. If you could be bottled, there wouldn't be any need for accelerometers or pedometers or motivational interviewing, because your academic prowess, generously shared with us all, would be very effective on its own. So thank you for that.
Oh, thank you. Thank you so much, Judith. I just realised there were two really important thank yous that I forgot. One was to say thank you for Janice Jackson, who's organised this tonight, the event tonight. She's fabulous. I'm sure she's not here because she's upstairs pouring the drinks, waiting for us all to get up there. And the other one's to thank Duncan Larkin, who's going to be surprised I'm thanking him, but he has done, from AV, he's done a fabulous job on all the promotional materials for tonight, and also on both of our trials. He prepared a lot of the patient materials, which were great. So thank you, Duncan, as well. I think we should go upstairs. Up we go. That's great. Thank you. And that was a lovely introduction. Thank you. Thank you. Thank you. Thank you. Cool, I'm glad that's over. I'm ready for another. I can enjoy it now. I know. It was fabulous. Thank you very much, Jenny. Thank you. Thank you. Did you manage to get it? You think you did? Oh, can you get it off for me? Lovely. And then when they get you. Yeah.